the chair of the healthcare portfolio for the Delaware League of Women Voters. And I want to, right up top of this introduction, I want to say a big thank you to the rest of the committee members who worked really hard along with me for this event tonight. Cheryl, Seal Tilney is our at the controls for our Zoom meeting, and that's a very demanding job. Thank you, Seal. Jennifer Sutton is going to be facilitating our chat Q&A sessions after each panelist. And Kathy Donegan just brings all of her skills and talents to everything we do. So thank you, all of you, for everything you've done to get this together. So first of all, I'm really delighted to welcome the whole audience and our panelists tonight. This is the first of 3 Zoom events that the League has planned between now and our in-person League Day, which occurs on Tuesday, April the 8th, mark your calendars, down in Dover. These 3 Zooms will be collecting information and ideas to feed into that in-person event. So we hope you can make it to all 3 of them. We're calling our series Successful Delaware, Healthy, Housed, and Educated. And we invite you to join us in exploring the intersectionality of these 3 topics. Together, we can identify potential legislative solutions to address known and anticipated challenges. Tonight's healthcare focus is on Delaware's silver tsunami, the name that's given to describe the ongoing and rapid influx of seniors into Delaware. The 65 and over age group is the one age demographic that is expected to significantly increase between now and 2050. Last August, Senator Carper said this, and I quote, "It's no secret that Delaware has a large senior population. After all, it's a great place to retire to, but we are woefully behind in our workforce to take care of them." How will Delaware attract the workforce needed to care for our aging residents whose healthcare needs are greater than at any other time in life? How will Delaware meet the housing, childcare, education, and healthcare needs of that workforce? Tonight, I'm thrilled to welcome our panel of experts. Our moderator, Tim Gibbs, here in back by the blue, will be introducing each of the panelists in turn. And I get to introduce Tim. Tim is a proud native Delawarean living the silver tsunami life. He's currently the director and principal investigator for the Delaware Health Force. Previously, he served for 16 years as the director of the Delaware Academy of Medicine and the Delaware Public Health Association. While at the Academy, he oversaw numerous initiatives, including the launch of the Delaware Journal of Public Health, the Delaware Mini Medical School Program. He took on the Immunization Coalition of Delaware from the Department of Public Health, the continued operation of the Academy's decades-old student financial aid program for Delaware residents attending dental and medical school, and the addition of the Delaware Public Health Association to the Academy of Medicine's programmatic scope. Tim is the recipient of numerous career achievement and public service awards, and we are most honored to have you tonight, Tim. Before I turn this over to Tim, I just want to ask anybody who has questions to enter them into the chat function on your Zoom screen. We aren't going to have direct, there are just too many of us here tonight. It gets to be very awkward trying to get the audience back and forth with the panelists. So Jennifer is going to facilitate the Q&As. She'll take your questions out of chat and pose them to the panelists. So I think we used to say the floor is yours, Tim, but I think now maybe the camera's yours.
But the camera is mine, and I finally decided to switch cameras because I was looking in the wrong place. Okay, so let's see whether we can make this magic happen here. Okay, with any luck, you all in the audience and viewers are seeing a PowerPoint screen. Can someone confirm that for me?
Yes.
All right, fantastic. So Judy, thank you very much for the introduction. I'm honored to be moderating this panel, especially as you mentioned, I am old. I am part of that silver tsunami. I was asked to provide a quick overview of what the silver tsunami means. And in order to allow this evening's panelists ample time to speak, I'm going to make this very short. So it's going to be like strapping into a Ferrari or a Tesla or a Corvette. I'm going to go fast. These PowerPoint slides will be turned into a PDF, which I will send to the League of Women Voters, and they can distribute them to those of you who are attending. So hopefully, as most of you know, if you're 65 or older, you qualify and are in fact one of the Silver Tsunami. And now let me make this go to the next one. So what does that actually mean? And I need to get here. In the United States in 2021, 17% of our population was 65 and older. In 2030, it'll be 20%. And about 2045, that number will be about 23%. That's in the United States. In Delaware, by 2040, the 65 and older population is projected to increase to over 41%. In other words, our population demographic is at this point very weighted towards much older adults than children and young adults. And so, what does that look like? And here we'll move on to the next. So what's that look like? This is a bar chart from the UD Center for Applied Demography's Ed Ratlich. He's one of the greats in demography, and it shows population trends over time. And if you focus your attention on what I've, highlighted and surrounded in red, that's where we are this year. And you can see the numbers of people falling into different age categories. If you look back to 2020 to the left or forward to 2030, you can do a quick number comparison and see that there's a very dramatic increase in 65 plus, and of course, 45 to 64 plus. So if we only look at this year and we're 65 plus, 5 years from now, we need to add the people who are 60 and so on. And especially in comparison to those younger ages. So looking at this then in another manner, this is based on data from the US Census Bureau, and it graphically shows the growth of the age groups with the 65 plus leading the pack, the 50 to 64 short before, not too far behind, and you can see that the numbers are over 200,000. Moving on to yet another way to look at this. For those of you who like donut charts, this graphically shows on the left-hand side 2010, on the right-hand 22. This is US Census data, and you can compare the portions, the percentages of that donut that are the 50 to 64 in purple and the 65 plus in the middle of the two shades of blue. So what does this mean in terms of, so struggle with the mouse on my side, in terms of Delaware? So here's the state of Delaware. And if you look at the map overall, and this isn't the best map, but it served the purpose, you can see that downstate, the amount of red is not only geographically larger than it is up in the north part of the state, but so is the middle age. So except for in very northern Newcastle County, Sussex County is growing very, very quickly. And we've all heard the reports, whether it was from Tom Carper or US News or Wall Street Journal, saying everybody retired to Sussex County, Delaware, which is great. And it's also, frankly, problematic when you look at it through the lens of healthcare provision and support services. So how does the Silver Tsunami relate to, our health conditions? And you can see an extensive list here. I'm sure you all are familiar with some of these already, maybe vision or hearing loss. And as we grow older, more and more of these things compound for many, but not all adults. And that's called comorbidity. And along with comorbidity and the care that it deserves comes polypharmacy, which is having usually I think it's defined as more than five prescriptions or more at one time. So there's a management and keeping up with the primary care team or whoever's taking care of you. And so there's another important factor to keep in mind is that while that is impacting us as members of society, similarly, it is impacting a similar portion of the healthcare provision team overall. And that's all manner of primary care and specialists and nurses and you name it. So what's good for one is good for all. And that's kind of the way it goes. So moving on to the next slide here. So who cares for primary care, older adults on the front line? And that would be primary care practitioners. And in this case, we divide these out in a number of different ways. We've got physicians, we've got nurse practitioners of different types. We have specialists as physician assistants. And then there are those are the people who work in independent and quasi-independent practice. And then they have a whole support staff of people who are helping them do their jobs. So this really slices through not only the general population, but also the healthcare provider workforce. And here, looking at this in yet another way, let's get this here, this is the Board of Medical Practice, the board that licenses physicians and physician assistants. Anyone from that left line, from the red line to the left, is of retirement age right now. And there's a lot of bars with a lot of numbers there, and some of them are fairly large numbers. I was going to put the numbers in and realized y'all wouldn't be able to see them, so just take my word. We're losing a lot of people. Moving on to then the Board of Nursing, we see a similar phenomena in the Board of Nursing, although not nearly as dramatic as with physicians. And then finally, with physician assistants, again, not as dramatic as in MDs, but it is definitely a pervasive challenge for us to deal with on the workforce side. And so this leads me to my final point before I introduce our first panelist. Be your own best health advocate or be that person for somebody else. I know that all of you hopefully know everything that's listed here. I'm not going to read through it. You know the points. Take care of yourself. Keep up on your immunizations and everything. And importantly, if you're a primary care provider or a member of their team, somebody you count on, is a colleague and a peer of yours, age similar, you need to have a conversation with them and find out what their plans are. We're hearing more and more of practices suddenly closing, and it could be for a lot of reasons. Your primary care provider could retire. They could decide to change their association to being in private practice to a hospital practice. There are any number of reasons why. Heaven forbid they should die. But have that conversation now, be thinking about it now and be planning for what's your next move. The other point I want to make is that primary care today is more than just what is provided by physicians. Nurse practitioners are fantastic. Physician assistants are fantastic. The PAs operate under physician guidance. Nurse practitioners are truly independent. I've got one. I love her. And so I know that for people who have lived as long as we have, change could be difficult, but do consider the potential benefit if you're having difficulty finding a physician primary care provider, that there are other options out there. And I'm sure that my colleague, Chris Otto, will talk about that. So at this time, I'm going to stop share, and I'm going to go ahead and introduce Sue Getman. And again, I need to get my mouse in the right place. There you go. So Sue is the Executive Director of the Delaware Association for Home and Community Care. She was the former Director of the Wilmington Senior Center and the Mid-County Senior Center. She was also the chair of the executive committee for the National Institute of Senior Centers for 2 years and did other work with them in the back. In other words, ladies and gentlemen, she's an expert in this. Sue, I will turn it over to you to talk about what your group does and what your challenges are and what you see coming down the road.
Thank you, Tim, and thank you for the opportunity to participate in this panel discussion about Delaware's aging population and our healthcare workforce. As Tim stated in his introduction, I'm with the Delaware Association for Home and Community Care, which provides communication, collaboration, and education for home care providers and facilitates high quality and comprehensive home care services for Delaware residents. The subtitle of this event is What Keeps You Up at Night? I'm going to highlight my reasons as melatonin moments, so you'll be aware of my highest concerns. I want to look first at the broader picture of aging in Delaware. I understand both personally and professionally that getting older isn't easy, but it's still a very good thing. If we aren't aging, we aren't around anymore. But thoughts about later life are taboo for most people until they realize that they're part of the silver tsunami themselves. Delaware residents, and I dare say most Americans, are not prepared to grow older. As a result, they don't take action to prevent aging challenges and aren't ready to navigate life after 60. Retirement savings are slim or non-existent, wills and advance directives aren't written, and families postpone hard conversations about how and where loved ones want to live until it's too late. State government, despite talking about our changing demographics, doesn't prioritize aging. Campaign platforms during the past election cycle included little mention of how to support and care for older Delawareans. Last fall, for example, a Delaware Women's Status Report was released from the Delaware Office of Women's Advancement and Advocacy. It included no information about Delaware's older women residents. So here's my first melatonin moment. How can state agencies, in partnership with the nonprofit and private sectors, prepare the state for the silver tsunami, not just react to it when it happens? We need a collaborative effort to help Delawareans grow older in ways that are positive and healthy, enjoying their later years, and so we can effectively support the people we care about. One of the most essential services on the aging continuum is home care. A study published by AARP in 2021 found that 76% of Americans over the age of 50 would like to stay in their current homes or communities, and more than 2/3 of the respondents indicated their preference for in-home assistance from paid professionals or family if needed. Home care promotes aging in place, allowing seniors to maintain the highest level of independence possible in the place they feel safest and best cared for, home, wherever that person resides long-term, whether it's a personal residence or a long-term care facility. Home care, preferably from a state licensed agency, is offered at various levels depending upon the individual's needs. Direct care workers from personal assistance service agencies help clients with activities of daily living and provide companionship, transportation, and homemaker support. Home health aides are also direct care workers, but they're required to have additional training or experience so they can provide a higher level of service under the supervision of a registered nurse. Skilled service providers offer services that include nursing or home health aide care. Registered nurses and licensed practical nurses help individuals with chronic illnesses, disabilities, and serious injury. Skilled care is provided to pediatric patients as well as to the elderly. And hospice providers offer palliative and supportive medical and other health services to terminally ill patients and their families. Paying for home care can be a significant and sometimes insurmountable challenge for individuals and families, which creates the next melatonin moment for me. Out-of-pocket payments can be made by individuals and families from personal assets that can quickly be depleted. Long-term care insurance policies can also pay for home care, though premiums are typically high. Medicare is the federal program covering people ages 65 and older and younger people with certain disabilities. It is widely misunderstood and assumed that Medicare will pay for all home care. It does not. Medicare home care coverage is primarily used only for acute conditions and is generally episodic. Medicare does not pay for long-term home care or for an individual to live on a long-term basis in assisted living or skilled nursing. Medicare also pays for for hospice services. Which brings us to Medicaid, a joint federal and state program that helps with home care costs for some people with disabilities and/or with limited income and resources. Medicaid is the largest payer of long-term care, covering about 60% of long-term care services nationwide. With assistance from elder law attorneys and some community services, families can do Medicaid pre-planning, protecting assets in advance of a healthcare crisis so that when needed, Medicaid can pay for home care. Attorneys can also help with Medicaid crisis planning so that benefits can be accessed. But, and this is part of the reason that the thought of paying for home care makes me lose sleep, older adults and their families need to know about these options in order to take advantage of them, and most do not. Once a need for home care is identified and a source of payment is available, the real challenge to obtaining vital, life-sustaining, and often life-saving home care begins. And this melatonin moment is brought to us by workforce. Quite frankly, the demand for home care exceeds the supply of workers. There are a number of reasons for the shortages. As I said previously, people want to receive care at home, a fact that was exacerbated by COVID-19. But demands during the pandemic led to burnout and industry departure of many home care workers. Inflation has created an economic reality in which home care wages can't keep up. Other jobs pay more, have less stringent pre-hire requirements, and are easier. Home care is hard work. Sadly, home care isn't valued as a career option by many nurses who see hospitals and medical practices as more prestigious and with higher pay and better benefits. For direct care workers, there are no apparent career pathways. Many of these workers also face barriers because they are members of Delaware's marginalized communities. 85% are women, 74% are women of color, 20% are immigrants. Lower wage direct care workers struggle to make ends meet. 33% live in low income households and 41% are housing cost burdened. Some are beneficiaries themselves of state-funded programs such as affordable housing, SNAP, and Medicaid. They must restrict how much they work in order not to exceed the income limits for the benefit programs they rely on, which means they can't fill shifts and provide care for the home care recipients who rely on them. Home care workforce shortages can also be linked to Delaware's childcare industry. Both home care and child care are vital lifelines for families and individuals across our state. But just as home care faces increased demand for a shrinking supply of services, so do child care providers. When parents who are home care workers can't work because they lack child care, elderly and disabled clients aren't served. The most critical reason for the shortage is wages, which have not kept pace with inflation, and in the case of Medicaid, have not been prioritized by Delaware state government. Private duty nursing received no increase in Medicaid reimbursement rates between 2006 and 2021, and have been increased only twice since then. Direct service Medicaid reimbursement rates were not increased between 2012 and 2022. But despite 3 increases, They are still below the lower bound tier identified by a state-sponsored market rate study conducted in 2024. When we speak with legislators, we remind them that home care saves state Medicaid dollars. Worker shortages resulting in unfilled home care shifts mean more institutionalizations and hospitalizations at significantly more expense to the state. In preparation for tonight, I asked our association board what keeps them up at night, and those who responded included some version of these statements. We all face the challenges of a diminished workforce. Being able to provide staff for existing clients is our top priority. We also worry about how to safely accept new referrals with our limited existing staff. When referrals aren't accepted, home care isn't provided. Open shifts and worker call-outs mean clients are left without coverage. This is the biggest, most consistent, and most critical melatonin moment for me. Without home care, older Delawareans are languishing, suffering, and struggling at home, and may need to leave the place they want to be for a hospital or a facility in order to stay alive. So what can be done? Our association's legislative priorities and proposals for consideration are to first increase the Medicaid home care reimbursement rates for private duty nursing and direct care services, improve the home care background check process to aid in recruitment of vital workers, establish standing legislative committees on aging in the General Assembly, direct and fund an ongoing and far-reaching communications and service strategy for aging Delawareans, telling them how to prepare, what available resources there are, and how to access them. And to promote recruitment and retention of the health and home care workforce with solutions that incentivize employment and provide opportunities for career advancement. Last week, I volunteered for my monthly Meals on Wheels shift. When I knocked on the door of one apartment, outside of which is a sign saying, "No smoking, oxygen in use," I was greeted by a frail woman who had a nasal cannula with a tube trailing into the room behind her. When I asked how she was, she told me, "I'm not good. My aide is sick and can't come this week. So if I can't go to my son's, I'll have to go to the hospital. And I really don't want to." My concerns about supporting older Delawareans and maintaining a home care workforce can be intense. But my sleepless night, for this elderly woman and too many others, it's a living nightmare. Thank you.
Thank you, Sue. Perfect timing. I'll turn it over to our moderators. Are there any questions?
So we have one question in the chat, which I think Sue addressed in a general way, but maybe can provide some more details about the current state of availability of home health care workers in Delaware.
Well, that's a good question. I don't have exact numbers. That would be, I think, impossible to determine. We are going to be getting a data report in a couple of months that will help us see how many Medicaid hours were authorized versus how many were actually filled. So I would be better able to tell you at that point. But I do know that more home care is authorized that can be provided, whether it's personal care and direct services or skilled nursing. So people are waiting. They may get partial shifts during the week, but not a full shift. So it is a challenge, but I don't have exact numbers, I'm sorry to say.
Right. Well, while you were answering that question, we have a couple more that came into the chat. One person asked if there are any bills in the state legislative assembly or discussion about proposed legislation to allow family members to be paid to take care of relatives.
There are programs for that. I won't go into the specific details. Some of the providers who are members of our association do use family members. They employ them and they are paid with Medicaid reimbursement. There are other programs with using self-directed care that can include family members, often for pediatric patients that happens, as well as for older adults. So this is a possibility, but it's not necessarily widely known how to do that. So I do suggest, if somebody is interested in doing that, to talk to a licensed provider and see what they can connect people to, so that families can be paid for the service.
Very helpful. Thank you. And the last question asks about, when was the last time that salaries, there was an attempt to increase salaries for home healthcare providers under Medicaid, and how did that turn out?
That's a good question. For private duty nursing, there have been 2 increases since 2006. As I said, the last one was for fiscal year 2023. The rates are still below the what inflation, or sorry, the U.S. Bureau of Labor Statistics says they should be based on inflation from 2006 to today. But there were 2 increases then. I want everybody to keep in mind that when we say reimbursement rates and that increase, that rates include wages, training, transportation, administration. There are a lot of things included, but we did a survey internally. We actually had a third party do the research. And after the second increase was implemented for private duty nursing, we did know that the majority of the rate increase did go to the nurses. For the direct care workers, the last increase was for this fiscal year. It went into effect January 1st, 2025. That was a 5% increase, and there were increases each of the 2 previous fiscal years. But again, it's still below the lower bound tier of the market rate study results that were obtained last year.
All right, thank you. And the last comments are to thank you, Sue, for your really nice presentation.
Thank you.
All righty, excuse me there. So next up, going in alphabetical order by last name, we have my colleague Cheryl Heiks. Cheryl's the Executive Director of the Delaware Healthcare Facilities Association. She's also a member of the Advisory Council for Delaware Health Force that I'm the Director and PI for. And Cheryl, your 15 minutes starts now.
Well, thank you, everybody. And just like Sue said, and I may ditto a lot of what Sue just said, I want to thank all of you for giving us this opportunity. When you talk about silver tsunami and over 65 being the number, and when it comes to long-term care, which is who I represent, and we represent as a trade association, a little nonprofit trade association, 2 employees. We have 95% of all the facilities in Delaware as our members, lots of associate members that are in home care, hospice, independent living, you name it. But we have found that the most important issue with this silver tsunami is that it's already here. It's already here in Delaware. We've been such a popular place to retire for so long that, we've gotten, more than our little per capita slice of this pie. And as somebody who's been in government relations for more years than I would care to admit, I have been harping on this issue of our healthcare workforce shortage. We just have not been able to find a solution. The state hasn't been able to find a solution. There's an effort to do this around primary care doctors. There's an effort to do this maybe around psychiatry. There's an effort to do this around substance use disorder treatment programs. But we have not yet figured out how to solve for this. And as Tim mentioned, and I count on Tim and his group to be able to give us the most up-to-date data, we are far outnumbered by those who need care than those that we have available to provide care. And if it's in our environment in long-term care, which is, very highly regulated and oversight, I don't know if you can see this book. Maybe I'll have to unblur my background. That's the federal book, just one book of the latest updates and survey guidance for long-term care. That's federal. Delaware has its own. So it's one of the most highly regulated industries that you can name. So it's a tough place to work in terms of oversight and people watching what goes on, but it's also a very rewarding for those kinds of people who care about seniors and individuals with disabilities. So I'm going to just give you a couple little statistics, and then I'll tell you about what keeps me up at night and those that I work with. Delaware has 47 skilled nursing facilities in Delaware. Some of those are associated with what's called a continuing care retirement community, which people pay in a sum of money and you're there for your lifetime and you have services. There's a total capacity of a little over 5,000 beds. Not nearly enough for what we can expect to see or need to see sometimes. 23% of them are nonprofits. We have a pediatric super skilled facility. We have 2 of those for individuals with intellectual and developmental disabilities, and 3 state facilities, one of which is the Veterans Home. Since the pandemic, there's been a tremendous change in that environment. More than half have changed ownership. And almost all of them, with very few exceptions, have changed leadership in terms of who's running the building on a day-to-day basis. One of the things that keeps me up at night, I started this job just before the pandemic. When it came to planning for the pandemic, the long-term care, home care, home and community-based centers weren't on the planning process when it came to disaster planning. I spent the morning today working with a collaborative group of people from hospitals and public health to try to find a solution to that. And I think now we've learned one of those lessons from the pandemic about how things can be made better. So I hope that we can continue to see improvements in that, see enhancements of that, so we aren't in this situation again. Can everybody hear me okay? Because the cleaners have just decided to vacuum outside my office. So let me know if you can't hear me. So the next best thing is when people enter into long-term care and skilled nursing facilities, there's generally an admission either from the community, but usually from a hospital. They are not necessarily there forever. About 50% of them, but anywhere between 50 and 55% of them get discharged back to the community. And that's where we count on folks that work with Sue and certainly folks that work with Chris, because that's where that home care and that connection really comes in. I see this as a circle. It's, home care, hospitals, long-term care, and it can go back and forth. It's a very fluid environment when people reach a certain age or have a certain need. Our average residents are 77 to 78 years old. They have at least 7, usually about an average of 7 ADLs or needs, 7 different kinds of needs that they associate with why they're in a facility, why they need help. It could be getting dressed, it could be getting fed, it could be toileting, all kinds of things. There's probably the 51 to 52% now in the last couple of years have some form of dementia, which is one of the other things that keeps me up at night. That number continues to grow. And luckily people are able to stay at home longer, use medications. Pharmacy is being very helpful. People can stay low, but when they get to a certain stage, it becomes very difficult for them to be able to necessarily always stay at home unless there's lots and lots and lots of resources. And there's, I'd say probably out of all the days that are out there, there's an average long stay, people that have been there longer than 100 days in long-term care. That's about 3,885, times during the year somebody's been there longer than 100 days. 61 to 62%, around 60 to 62% of our residents receive Medicaid, which means for whatever reason, either they've done that planning that Sue mentioned or they're in that kind of economic situation. And that's why we rely on Medicaid. We rely on the work that we've been doing with the state government, and many thanks to those in the state government that have helped us make a change. There was not an increase in reimbursement in Delaware's long-term care facilities. Sue talked about rate increases for people. We're talking about reimbursement for Medicaid. for 16 years, since 2008. The first increase in that rate happened effective January 1st of 2025. That's the first one in over 16 years. So they self-funded, the buildings self-funded through a bed tax, and that gave a little bit each year that helped things going. And then when the pandemic happened, the wheels went off the cart. There just wasn't the money to pay for things. The staff wasn't there. Inflation went crazy. Staffing wages and all the wages for everything skyrocketed. So we lost 8 buildings in terms of closure nationwide. It's a lot more than that. And we do not have the ability to replace those in any way. The kinds of investments that are involved in producing a post-acute center, which is a step down from a hospital, which is what a skilled nursing facility is designed to be. There's just not people investing in those. So a couple of other things that keep me up at night. Probably like many people on the call, I feel like I'm watching a storm happening when it comes to things that are changing in the federal landscape. And it's not the time to get up on the surfboard and try to stand up. It's the time to be sitting on a chair on the beach and riding it out, because this is not going to be a calm sea for quite a while. So I think we all need to be flexible, bear with us, continue to be vocal and be great advocates for all the people that we care for, be advocates for each other, and utilize the combination of things that Delawareans have always done well together is when we, lock arms and we figure this out. The other thing that keeps me up at night, and it certainly involves many of our buildings. They're not new buildings. Many of them are older buildings. There are infrastructure issues. There used to be a reimbursement when it came to capital costs for improvements to buildings, and that also froze back in the 2008, 2009 years. We don't see a lot of that anymore. And I do think that we have many buildings in a beautiful part of our state that is low-lying geographically. It's not at sea level, but low-lying in terms of being able to, if there was a flood, if there was a direct hit of a hurricane, like Hurricane Sandy, hit Jersey and New York area a few years ago. If that came and hit Rehoboth Beach, how would we get all of we have emergency plans. We have, mechanisms to get residents and buildings out, but there's only so many roads that you can get out of there. And it's not just our buildings that everybody else would have to leave, but a lot of other people who are not necessarily counted, in a facility, in a hospital, that would have limited places to go. And you look at what happened in California. We had 2 nursing homes, one assisted living, one nursing facility, burned to the ground. They had 30 minutes to evacuate in some cases. And you may have seen it on the news, nurses and others, volunteers, pushing loved ones and pushing residents down a road in a jerry chair or a wheelchair if they could, to get them out of there. Luckily, they all did. They were all successful, but that had to be a traumatic experience. And where do you go? How do you get somebody someplace safe in that kind of emergency environment? So connecting with our emergency services, our directors of planning and development within the state, our hospital partners, our home health partners, we need to find a better way to make sure that this little small state doesn't have any kind of disaster like that impacts us. Hopefully we've learned a few lessons from the pandemic. I also wanted to mention there has been some federal changes or proposals around staffing mandates. I think that may or may not happen in the near term. It may get postponed a little bit, but Delaware, something like 96% of the facilities in the country would not be able to comply with those requirements. And Delaware's right in there. We have about 4 buildings that would be able to meet those numbers. And there's no money to be able to pay for it. It came with a huge request for increase in staff and requirements and $0 to do it. So that's going to be an impressive feat. If anybody can figure out how to do that, please let me know. I'd like to know the secret for that. The other issue that I think we all have is finding the right people to work in our environments, caring for each other, caring for our our ill and injured Delawareans, are those with disabilities, are pediatric patients, you know, our age, whether they're at home or in a building or in a hospital, that takes a special kind of person. And that's not everybody that's available in our workforce. So we need to try to find a way to build that empathy, build that connection to each other, and find a solution to some of these issues. Workforce housing, ideally, is a big plus. I'm all for that. I think affordable and workforce housing is one of our solutions. We've been working very closely with UD and others on preceptorships and clinical rotations for nurses and other students, but it is a struggle. And I certainly would appreciate the help of anybody that's a member of the league or anybody that's here tonight in helping us get to make some improvements in this area. Thank you.
All righty. Questions for Cheryl?
Thank you, Cheryl. We have a question about the distribution of long-term care facilities by county in Delaware.
Well, I want to say there's two kinds. There's a skilled nursing facility, which is that post-acute, post-hospital setup, and then there's assisted living. So let me give you both. There's two different statistics to give. We have 27 of those skilled nursing facilities in Newcastle County, 9 in Kent County, and 11 in Sussex County. And then when it comes to the assisted livings, they're a little bit different. Now, assisted livings have they're not currently, they probably will be in the not too distant future, but they're not currently truly regulated by the federal government. Delaware has regulated assisted livings for a long time. And there's more coming. There were 6 pieces of legislation last year around assisted living and adding additional laws and regulatory authority for assisted livings. There's 34 assisted livings in Delaware. There's a capacity, a total of 2,744 beds. There's 2 that focus on memory care, 1 that focuses on brain injury. There's 2 of them. There's a couple more under construction, 2 in Newcastle County and 1 in Sussex. But all total, there's 22 in Newcastle County, 5 in Kent, and 7 in Sussex. The big difference between assisted living and skilled nursing facilities. You can use Medicare for some of skilled nursing if you're receiving some type of therapy and other needs. There's a limit to the number of days that you can get qualified for that. You may or may not qualify for Medicaid in that scenario. But in assisted living, there's very few assisted livings that have any kind of Medicaid funding. There's really 2. I mean, there's maybe a bed here and there in some of these buildings, but there's really only 2 that have a strong Medicaid population. And that's Ingleside in Wilmington, and then Peachtree, which is for traumatic brain injury residents in Sussex County.
Thank you. We have a question also about using the potential for using large empty buildings as possible places for long-term care. And the questioner doesn't describe, I'm not sure if they're referring to office buildings or what exactly. Has there been any discussion about that?
There's been some issues or some interest in finding places within unused space in St. Francis Hospital, for example. But I'll say one of the biggest areas where we need assistance, well, there would have to be some funding to associated with this, is we really could use more long stay behavioral health settings for individuals, seniors, and also for I'm getting the 2 signs, so I think that means I have 2 minutes, and as well as those with substance use disorder, which is a growing issue in an older population.
Tim, do you want to save the remainder of the questions for the end of the discussion?
I think so, to give Chris his time, and then we can open up the dialogue. Sound good? Cheryl, thank you very much. So hold on, I'm furiously taking notes and I keep on losing my documents on my desktop. So one moment, please. Okay. So next we're going to hear from, again, a colleague of mine, Chris Otto, MSN, RN, CCRN. Chris is simultaneously the executive director of the Delaware Nurses Association, who represents Delaware licensed practical nurses, registered nurses, and advanced practice registered nurses, within which CNS, certified nurse specialists and nurse practitioners reside. And he is also a practicing nurse on the floor, I believe, primarily at Christiana Care. Like Cheryl Heiks, Chris is also a member of the Advisory Council for Delaware Health Force. Now I'll turn it over to Chris. Thanks.
Thanks, Tim. Glad to be here. Can't decide if going last is beneficial because so much has already been said, or problematic because I've added to my notes several times after hearing from my colleagues. So I'm going to do my best here to stick to about 10, 15 minutes and leave plenty of time for questions at the end. Those last two that came in the chat are very pertinent across the board and could be another webinar in of itself. Pay parity, compensation, work environments, but regardless of, setting. So I have a unique role in being the leader of the association in which we advocate for, seek to advance the profession of nursing. But additionally, because of the shifting healthcare demands and environments, we are now in the workforce development space. And we're going to talk more specifically about that. Want to start with the workforce needs for nurses. It is vast. And I would also say we are in the midst, as Tim noted, with the health professionals of our own silver tsunami. The nursing profession is aging itself. And the dynamic that wasn't captured in Tim's slide, and not because he missed anything, it just is hard to capture in the data, is what I'm seeing as a nurse leader and practicing nurse is the nurses that are, and my colleagues can attest this, the nurses that are entering the workforce today, they are not necessarily staying in those direct care sort of bedside positions that we're talking about in hospitals, in nursing homes, in home health agencies. They are getting a couple years of experience and then they are moving on to numerous other exciting opportunities and roles. However, you may see licenses and think, oh, that's great. We have, a supply of nurses, but that doesn't necessarily tell us that they are directly providing care to individual seniors, children, etc. So, and in the profession itself, the challenge with our silver tsunami is that is a wealth of experience and knowledge that is leaving with the nurse that's retiring. So we have nurses, and we know this unfortunately from the data that are graduating. They don't feel prepared to enter the work environments of today. So that's where mentoring, preceptorships, and the supervision, the tutelage of our experienced nurses is critical in helping to foster that development, foster the resiliency and the desire to stay in these particular roles and settings. We have a great need to diversify our nursing workforce, as Sue said, and can similarly be noted for the nursing profession overall. We're about 85, 86% female profession, about 60% still white female. And so there's a great need to diversify our workforce. I'm one of the 12 to 15%, depending on which survey you look at, male nurses, and certainly not a minority nurse myself. So we need to better match our workforce to the communities that we're caring for and in the settings that they want to be cared for in. And that takes some strategic initiative and partnerships across the educational institutions, not early childhood, but middle school, high school partnerships to get students exposed to the health career pathways. And then additionally with the employers, the healthcare sites to accept those students for internships, shadowing experiences, so that we get that wide array of experience to know a nurse just doesn't work in a hospital. A nurse works in a patient's home. A nurse works in a medical office. A nurse works in your school, all the areas that we know nurses are in. I mentioned this, but I just really want to hit home that a huge bottleneck in the nursing workforce space is a shortage of a need for more instructors in the educational institutions so that we can accept more nursing students. At the federal level, there's a group, the American Association of Colleges of Nursing, and they work with the colleges and universities across the nation, and they report at least 100,000 qualified nursing applicants turned away from nursing schools every year because there just aren't enough seats, and that's because there aren't enough faculty to accept those students. Another opportunity for pay parity, if we have any. I know there's some nurses on the call, but another opportunity for some pay parity because it's a major pay cut to become a nursing instructor, to go work at Del Tech, the universities, et cetera, than what you can make at the bedside. So another area where we're severely lacking nurses is on the instructor side, coupled with the preceptorships while a nurse is in school and the mentorship after the fact of once a nurse is, graduated, licensed, and in practice. We've seen it exacerbated by COVID-19, but it's always been there, will always be there, a certain percentage of burnout, dissatisfaction within the profession that leads to less nurses, volunteering to take that student, volunteering to orient the new employee. We're even seeing employers now rely on and implement more frequently preceptor incentives to train the nurses once they're employed in a hospital or in a facility. Once we break down and get into Sue's on another task force, she mentioned private duty nursing, but there's a statewide task force specifically looking at private duty nurses because of the severe shortage. That's one example of a specialty nursing practice that is facing its own significant shortages. Cheryl hit home on the staffing rule and not having enough registered nurses, CNAs, to meet that demand in the long-term care sector. So again, you need to craft and work both at the state and federal level to really look at some innovative ways to incentivize nurses to go in that space. And I got to tell you, it's not, the solution isn't always the tuition reimbursement or the tuition payback, because oftentimes that will come with, a requirement to work, in a certain area or a certain facility for a number of years. And nurses are enjoying and looking for a little bit more freedom and autonomy, so they don't necessarily want to be tied down. So we have to get more creative with statewide and federal, tax incentives, rebates, et cetera, to really capture, the interest and the desire to stay in these areas. Workforce data continues to be a challenge. Everyone on this call knows, and Tim is leading the charge and getting us more robust data. We're talking about it in the advisory group in the Health Workforce Subcommittee of the Delaware Healthcare Commission. And for us in particular, for nurses, it's Delaware specific data. However, the phase 2 has to be a regional approach to that because of our multi-state licensure compacts. You don't have to have a Delaware license to practice nursing in the state of Delaware. You can live in Maryland and have a Maryland nursing license and drive 15 minutes over the border and work in a Delaware facility. And that doesn't mean that we're going to capture that individual, in a licensure system or otherwise, and understand how much they're working, what type of setting they're working in, and other demographic information. Conversely, just because I'm licensed here in Delaware does not mean that I'm working actively in Delaware. I could be delivering telehealth to patients in Florida or driving across the river and practicing in New Jersey. So the workforce data is what we have today, but it's also getting to what's missing. And so that's a key component of what we're working on in these interprofessional groups. Now, a couple things that are keeping me up at night, and then we'll move into some of the initiatives and recommendations. This is where I added to my list based off of what my colleagues were discussing. First was there's a lot of changing dynamics and expectations, not only within healthcare, but within the sectors or individuals or organizations involved in that. So employers, the nurses and healthcare workers themselves, patients and families, everyone's coming to these settings with expectations, and those are shifting. So what we thought we knew 5 years ago, pre-pandemic, has to be updated and evaluated today if we're going to. This is particularly germane when we talk about retaining a workforce, attracting and retaining nurses to work in the state of Delaware. Again, those expectations are now different in a post-pandemic world, so we really need to get updated evidence and research to understand and apply programs and strategies that will work for today's workforce. We can't depend on what we were doing 5 or 6 years ago because the world has shifted dramatically since then. And so just for me as a nurse executive and leader of the State Nurses Association, that's what we're constantly trying to pull out from nurses is, what it is that they're looking for, what their priorities are. And we have heard it's not always compensation. It's a big part. It's definitely in the top 3, but sometimes work environments themselves, things like violence, staffing, leadership support, access to additional resources, those can take over as the driver of attrition and turnover within nurses. It's not necessarily just the compensation piece. And then another thing that keeps me up at night that I added to this list is that, especially as the head of the Nurses Association and doing some workforce development work, is that everyone needs nurses. So, like I said, no matter where healthcare is delivered, you're going to find a nurse there. They may not be right on the front lines, but they're definitely behind the scenes. Your schools, your correctional facilities, assisted livings, long-term care, home health agencies, acute care settings, ambulatory surgery centers, you name it, there's a nurse there, public health. Geez, that went quick, Tim. So everyone needs nurses, and being able to effectively meet those needs across the entire healthcare spectrum, and not just providing a nurse, but like Cheryl indicated, nurses that are passionate, compassionate, invested in the areas that they're in, that are diverse and prepared to meet the challenges of today's healthcare environment. So that takes a lot of coordination across different industries. Now, the good news, what are we working on? It's not all doom and gloom. We've got a lot of great work happening behind the scenes, and for us in particular, and for the panelists that are joining the board. The big one for us is the building and launch of the Delaware Nurses Workforce Institute. It is a public-private partnership. I can't cover this in 2 minutes, but we will definitely follow up on it more. It is the warehouse, the repository to really collect, analyze, and dive deeper into just the nursing workforce issues. It collaborates and works with Delaware Health Force, Health Workforce Subcommittee, Dimer, Diter, all the health professional groups, but it is going to do those deeper dives And then once the data is available and continuously being turned out, then they will take on and get into the programming and the strategies and the policy and advocacy that we need to address some of these challenges. A few examples of the policies that we're looking at, already mentioned preceptor tax incentives. So giving nurses additional write-offs when they're taking more students for more hours to get them that education training that they need to pass their boards to obtain their license and enter the workforce. We're looking at workplace violence legislation, continuing to increase funding from the state and federal governments for nursing education programs. There's a bunch of federal work happening. Unfortunately, we have an incredible delegation at the federal level that is very supportive of nurses and the healthcare workforce. And then, Cheryl, we definitely have to talk incentives for putting nurses into long-term care settings, home health agencies. We definitely want to look at those strategies and funding to incentivize and encourage nurses to enter those spaces more, so that we can meet the needs and so that individuals, back to the silver tsunami, can age in place successfully, safely, and happily where they want to, wherever that may be, and the level of care that's most appropriate to them. So, Tim, I think I'm a minute over. I'm giving it back to you. You can take some
I'm
questions
going to
now.
reclaim my time.
Yes, please do. Reclaim your time.
Right, right. So, Chris and Cheryl and Sue, thank you. If it's all right with our League of Women Voters leadership, I've made some notes. How about if I do a little recap now and then we can really open it up to questioning? Is that okay? Judy? I'm going to guess
Yes,
that
yes, that's fine.
all righty. So one of the things that I wanted to start off with, and this may actually rankle my fellow panelists just a little bit, but in support of the state of Delaware and DHSS, since the pandemic and before, but definitely since the pandemic, there's a real heightened sense of urgency and commitment to addressing these challenges that the panelists have mentioned. The Delaware Healthcare Commission Subcommittee is one and the same as the Delaware Health Force Advisory Board. And what that means is that collectively, this one group of individuals, of whom Cheryl and Chris are members, we're speaking with the same voice. There's a lot of fidelity between Healthcare Commission focus and what we're doing as this public-private partnership. Governor Carney and Lieutenant Governor Bethany Hall Long were strong supporters of the creation of Delaware Health Force, and it didn't happen. It didn't hurt, rather, that ARPA funding became available. I mean, the spigot turned on from the Biden administration, and all of a sudden we had money that we didn't have before to do a lot of things. The Departments of Finance, Department of Labor, Department of Education, everyone's really been supportive. With our new governor, Matt Meyer, and with Lieutenant Governor Kyle Evans-Gay, that commitment, at least from what I can tell and what I have heard, absolutely continues. Workforce development is a major component of Governor Meyer's, agenda. Writ large, he certainly expressed, and the lieutenant governors expressed their focus on the healthcare needs, public health, population health of our little state of neighbors here. The continuing cabinet secretary, Gisette Manning, is fantastic, and it was nice to have a little bit of stability in all the changeover. And the new labor secretary, Lucretia, I can't quite say her name yet, Moultrie, and I already are scheduled for a meeting, and I imagine that there will be continued. So the good news is that while in the past things haven't been, we've talked about it maybe, and maybe did a little bit of kick the can down the line, I'm feeling very good. And I hope that Chris and others are as well, that we're at a turning point. There's another two things that I want to mention real quick. It feels to me, in my whole career, which goes back to 1985, like there's a new level of cross-departmental understanding and collaboration in the state that has not existed before. That's a wonderfully powerful tool to get everyone together. The cabinet seems to be really functioning in unison. And also, as we focus on the needs of our fellow Delawareans, there's a healthcare reform and financing group which directly relates to the cost, the effectiveness, the quality that impacts not only the state budget, but all of us as consumers of healthcare, which is to say, it is intensely complicated, but I feel better about it than I ever have in my career. I think at the end of the day, we need to be promoting an economy of caring. We need to rethink our formula for what it takes to support our changing population, be it aging or otherwise, and recognize that, as somebody said earlier, this problem's been around for a while. It finally smacked us in the face like a raw tuna out of the ocean, and here we are. Cheryl and I have talked a lot in the past. She's brought this up in committee. There at least were, as of a couple of weeks ago, a couple of CMS initiatives at a federal level to raise the raise the stakes and the attractiveness of working in nursing homes. Chris has mentioned incentive programs. If we could even just place nurses who are doing their residencies, quote unquote, into the nursing home environment and figure out a way to make the economics of that work out for all concerned, we may find that there are nurses who go, oh, you know what? I like caring for this population. However, inherently, it is a tough population to care for. I lost my mom last year. I had direct some experience with what it was to be a caregiver at end of life. Without the support of Delaware Hospice and CNAs and whatnot, I don't know how we would have done it. So those are just some of the things that spring to my mind. I think, as I say, the state is trying to do a lot very quickly, and all of this, of course, costs money, takes time to organize, and we have little money and less time to get it done before the wave crashes on us even harder. At this point, I'll stop and turn it back over to Judy or whoever.
I think I'll have Jennifer go back into the chat for a minute. We do have some
Sure.
backup questions.
So we have a couple of nursing specific related questions that I think were directed to Chris. So maybe we'll start with those. One person asks about nurses who are close to retirement becoming teachers in academic settings, how easy or difficult that is.
Honestly, quite easy. The challenge there is the school having the funds and the open positions for more instructors, again, to fill more seats. Additionally, making sure that there is the schedule flexibility and that the type of position I don't want to make generalizations here, but a nurse closer to retirement may not want to go into and do, 16 hours of clinical a week, but maybe looking for a different type of teaching or instructing opportunity. So making sure that there's the right match for what that individual is looking for at that point in their life, as well as the needs and demands of the school, as well as not just the open position, but the compensation for that position as well, is a challenge. So in theory, it's relatively easy to make that transition, but there's a number of factors that nurse is going to consider when looking at that opportunity.
Thanks. Another question has to do with nursing programs that might be in the works. One person notes that for a young workforce, potentially people who are entering the health workforce in Delaware, that needing maternity care is an important issue, and understands that University of Delaware is hoping to start a nurse midwifery program. Do you have any details about that?
I will share what I can. I know that they're actively exploring, and we are actively encouraging and supporting those endeavors to bring a midwifery program to the first state. Um, uh, so within, and then I'll segue to Wilmington University's announcement in their partnership with Christiana Care to launch a nurse anesthesiology program as well. That was something that we were missing in the first state for many years. We've had nurse practitioner programs. We had a number of clinical nurse specialist programs. Those are waning down, but we did not have a nurse anesthesiology program. Check that box. We've got that now. Nurse midwifery is the last program that we need. And we are actively working towards that. So
Lots
about
of good things on the horizon. Thank you.
yes.
Right, and I just want to throw in here real quickly that the Board of Nursing oversees the certified nurse midwives. The Board of Medical Practice oversees certified professional midwives. I can't help but think that there's an interesting historic reason for why that is the way it is. But in any event, there are actually two different types of midwives by license. And that's a topic for another discussion.
Women's health is a topic for another discussion as well.
Can I just bring up one example? Former Representative Paul Bomback worked very closely on the nurse midwifery issues in Delaware for a long time. And it was not an easy process to get that through. And there were lots of levels of different grandfathering of people that had certain skills and background. But I don't need to say anything to this group because you're all very interested in legislation and like me, love to spend time in Legislative Hall. But it was a very interesting day when that bill was finally making its way through and getting enough votes to get out and get voted on. We had a number of women of all ages from the Amish community in the building who were very active and proactive on that piece of legislation. The same day that a gun control bill was going on in General Assembly. So it was looking at two different worlds coming into place within Legislative Hall. So if you haven't spent time down there and with your league membership, please do. And we'd love to have all you help us on our healthcare workforce initiatives. We can use all the help that we can get in getting these things over the finish line and continue to work collaboratively.
Well, building on Cheryl's comments, we have a question about what we, either as individuals or as an organization, can help improve help address the pay issues for in-home and long-term care facility staff.
Unmute, Cheryl.
Well, maybe I'll let Sue go first because her strategy on this is different from a different funding source, and then I can explain ours.
Thanks. Well, of course, we cannot influence private pay from or home care providers who pay separate from Medicaid reimbursement. So what we can do legislatively is at this time Medicaid reimbursement for home care and I believe other services, it's not included in the governor's budget, so it must be put into the budget through the Joint Finance Committee. So for example, the Home Care Association and our advocates will be going to Legislative Hall to testify in support of raising the reimbursement rates on the day that the Division of Medicaid and Medical Assistance present their budget. So it's February 25th. So we will go and testify. We also do legislative visits, we talked with members of the Joint Finance Committee and other legislators in support of these rate increases. So specifically for home care, that's a way to influence what the rates are, and then subsequently that would trickle down to the wage increases for nurses and direct care workers.
And in long-term care, since this is the first real rate increase just happened January 1, buildings were using funds to be able to do a lot of shift differential bonuses, extra pay to fill shifts in buildings. The pay rates that went anywhere between the minimum of 12% to 35 to 40%. Then you add, there was an awful lot of use of staffing agencies and people that were coming in from other states or other places. As much as that is a needed resource and something that we value, it also doesn't allow for continuity of care the way we would, prefer. So it's an important, ace to have in the hole, but you really want to make sure that those folks, as much as possible, become permanent staff, and you can build that training and that relationships, and they'll get to know what the residents' preferences are, things like that, rather than someone who parachutes in to fill a couple shifts and then goes over to Pennsylvania to do a few more and somewhere else. There was also, some unfortunate nursing school scandals and fraudulent issues that happened called Project Nightingale. If you want a nightmare, that's that. Just read that. That happened over the last few years, and that continues to be the case. Primarily schools in Florida, but probably some elsewhere. And thanks to our excellent Board of Nursing and the members that are part of that, the staff and the folks at the Division of Professional Regulation that have been on that, like you wouldn't know, to be able to protect our Delawareans from people who perhaps are just skipping a few steps to be able to get that higher level of professional status. But we're all for any help. We're just like Sue, we'll be at the joint finance hearings, but we encourage you to communicate with us and get involved, especially if we can identify some buildings that are in your area, have you come take a tour, meet the people that are working there and what drives them, what interests them, and the residents. We're always interested in folks that are interested in getting involved with our residents and volunteering. So thank you so much.
Tim, can I wrap up on that question? Awesome. And thanks for bringing that up, Cheryl. I mean, Operation Nightingale is actively still going on. I was just on the phone with Pam, and there were a few more schools recently added and some more letters going out, unfortunately. But in addition to the advocacy around rate increases and more public funding for better pay rates for nurses and direct care workers, I want to particularly bring up that there are some strategies that we can deploy in the private sector as well, through fundraising, scholarships, educational support for direct care workers. There are so many strong CNAs, home health aides that want to go on and become LPNs, RNs, APRNs, or other various licensed health professionals. What we need to do, though, and the theme of the League Day with happy, healthy, housed, and educated is the perfect intersection, because what we need to do is take that lens and apply it to how we develop and move folks through an educational pipeline. It's not just the scholarship to offset the education, to offset the tuition. It is looking at that individual holistically. Are they housed? Is that housing secure? Do they have transportation? There are so many, we talk about social determinants of health. Well, I say it's the social determinants of learning and being successful in matriculating, LPN to RN to APRN, whatever that looks like for the individual. So it's looking into the private sector, those donors, those funders that, may have had experiences and are personally passionate about home health, long-term care, you name it, and may be willing to work with foundations and other professional groups to specifically infuse some funding to offset those costs and build up the workforce and help offset that pay parity piece. So it's the public strategy, but also the private sector that can really step up and help in this space as well.
Tim, do we have time for one more question or two more questions?
Two more questions. Why don't you pitch one of them to me?
Well, so we've had one question commenting on pay, but also inquiring about other features besides pay that can help retain a workforce. And I know Chris has talked quite a bit about this in the nursing arena, but maybe you or others could talk about it in other settings.
Right. So just rather quickly, we had a healthcare workforce summit last year, and a couple of the barriers, aside from pay, are the incredible hours for those people who do work at facilities, the level of stress on them, and whether they are taught resilience skills, whether they're given ample time to, have that break in their workflow. So a lot of this has to do with really just treating our fellow caring healthcare professionals as human beings and not as workhorses or mules in the overall system. The stress all on its own on a good day can be extreme, but caring for too many patients for too many hours in a row is just a lot. And I would encourage for Sue or Cheryl or Chris to add on to that if you want.
I can only speak for long-term care. I was a recipient with my mom of excellent home care services, but I can tell you nothing is quite the same as somebody being able to live on their own and with their own family and their own environment. A facility, no matter how good it is not going to be exactly the same. But for many people, they do not have the kinds of enriching home life and support that hopefully everybody on this call does. Not everybody is living in a safe environment or with care of people that are taking good care, taking their best interests at heart at home. And especially if someone is older or has an individual with disability, they're sometimes ripe for people who may take advantage of them in the community or elsewhere. So the workforce that dedicates themselves, hero is not a strong enough word. Warrior may be a closer word that may be appropriate. There's still people that are suffering from what I would call post-traumatic stress from the impact of the pandemic. What these people did for each other and for their residents and for their loved ones and others was nothing short of miraculous. Under-resourced, underfunded, under stress, blamed for everything. And they came out on top. People that love, they become their families in these situations. Unfortunately, a number of people that are in our buildings, their families no longer live close by. So they may come and visit, or they may Skype in or something, but they're not there all the time. Getting people to come and visit in our buildings, volunteer in our buildings, connect in our buildings, more staff, all those good things. But I want to say childcare would be a really nice thing to be able to add to our environments, having a close by childcare center on the same campus or closer for our workers and for others in the area, I think would be a really nice benefit, something we could work on together for, and adding ways for the children to be able to connect with our seniors and residents. They make a really nice combination, those two populations. It's really exciting to see sparks happen. So we're open to anything, open to any ideas, and we're interested in all the help we can get. So thank you so much. And thank you again for having us tonight, for having me tonight.
Well, I think it's time for a farewell here. This has been a very helpful, educational, informative, I'm thinking, I keep thinking, I can't wait to hear the recording so I can jot down things more clearly. It does seem like there's this vicious cycle of too few help workers for too many people getting burned out, resulting in more of the same. And so I'm thrilled to hear that the state is being sort of supercharged proactive at this point. And I just heard a lot of really interesting ideas come out tonight. So thank you all. I speak for the whole league, I think, in thanking you for coming and spending this time with us.
Thank you for
Thank you for
inviting us.
I think I want